Hello, I'm Dr. Anthony Wheeler, and I'm telling you everything that you need to know about pathology. Now, what's in this container? Well, that's urine, and it does not look normal. We're going to be discussing this and much more on this presentation of Urinary Tract Infections Pathology. This is covered in your book, Medical School Pathology and Step 1 Review. You can scan the QR code to get to the updated material. Urinary tract infections, what are they? Well, urinary tract infections are simply infections of the urethra, bladder, or kidney. To the right here, we can see an individual cell with numerous bacteria adhere to it. Those bacteria are E. coli, and they tend to be uropathogenic. Some particular urinary tract infections that you must be aware of include cystitis, sterile pyuria, urethritis, pyelonephritis, chronic pyelonephritis, and nephrolithiasis, okay? Now here to the right again, we can see that container with urine that doesn't look normal. That's because this urine contains pus, a condition known as pyuria. This is from a person with sepsis due to a urinary tract infection. Ascending infection is the primary cause of urinary tract infections, also known as UTIs. And females are more likely to develop it than males. Risk factors for urinary tract infections include urinary stasis, right? Multiple sexual partners, urinary catheter use, congenital abnormalities of the urinary tract. To the right here, we can see microscopy of white blood cells in a urinary specimen, indicative of urinary tract infection. And the CD68 immunohistochemical stain, as we know, tends to stain macrophages, right, as well as giant cells. And we can see that in this case of xanthogranulomatous pyelonephritis. And to the right here, we have imaging from a patient with chronic pyelonephritis with reduced kidney size and focal cortical thinning. Radiography such as X-ray can also be used to identify kidney, bladder, or ureter issues. Here we can see bilateral kidney stones that can be seen with a KUB radiography. KUB stands for kidney, ureter, bladder. Note the phleboliths in the pelvis, which can be misinterpreted as bladder stones for you future radiologists out there. Speaking of urinary tract infections, it's important to note that white blood cells can be seen under the microscope from a urine sample, particularly with patients with urinary tract infections. That's important to remember. Now let's talk a bit about cystitis. Cystitis is bladder infection. And for the MD PhDs out here, or out there, here is a bladder from a mouse. You probably have done a lot of research on mice. Yes, mice are susceptible to cystitis as well with their little itty bitty bladders. More importantly, for your purposes, symptoms of cystitis include fever, dysuria, urinary frequency, urinary urgency, oh, I need to go, and suprapubic pain. Laboratory results of cystitis include, importantly, a urinalysis with cloudy urine with greater than 10 white BCs, white blood cells, per high power field. Also important to note is a dipstick positive leukocyte esterase, and this is due to the pyuria and nitrates. And a culture greater than 100,000 colony forming units is the gold standard for diagnosing cystitis. Common etiologies of cystitis include E. coli in the majority of cases, approximately 80%, right? E. coli, as well as Staphylococcus saprophyticus, right? In young sexually active females, right? Klebsiella pneumoniae, Proteus mirabilis, and Enterococcus fecalis can also cause cystitis. To the right here, we have an H&E specimen from a patient with cystitis. This was a biopsy that showed severe, acute, and chronic inflammation with ulceration. And here we can see histology from a transurethral resection of the posterior superior bladder wall lesion, showcasing a cyst lining composed of stratified cuboidal epithelium, as well as a duct composed of cuboidal epithelium. And note in C, there's a ductal structure with a muscular wall in the continuity with the detrusor muscle, right? And here we can see actually a polypoid lesion that was obtained from a bladder biopsy showing intensely congested mucosa. That's all that red, particularly in the bottom left-hand corner. And there's this polypoid projection of the inflamed benign urothelium. This is polypoid cystitis. And here we have representative tissue sections from a patient in a study, A and B, and control in C and D, after a sodium potassium ATPase immunostaining. The black double-headed arrow indicates the urothelium. And here we have histology from cystitis glandularis. In A and B, you can see the typical cystitis glandularis, the urothelium showing the reactive changes and the underlying proliferation of von Brun's nests. In C, we can see intestinal cystitis glandularis. The sections show the presence of goblet cells, if you look closely, and a morphological similarity to colonic mucosa. Now let's talk a bit about sterile pyuria. Sterile pyuria is pyuria with a negative urine culture and more than 10 white blood cells per high power field, and leukocyte esterase is referred to as sterile pyuria, right? So if there are more than 10 white blood cells and leukocyte esterase present, but a negative urine culture, that's sterile pyuria. So if this specimen to the right here came back as a negative culture, that would be technically sterile pyuria. Again, with sterile pyuria, you will see white blood cells utilizing a microscope of the urine specimen, at least 10 per high power field. Now let's talk about another common entity that you must be aware of: urethritis. Urethritis is typically caused by Neisseria gonorrhea or Chlamydia trachomatis, right? You must know that. Dysuria is a common urethritis presenting symptom. Now, pyelonephritis, what is that? Pyelonephritis is kidney infection. To the right, we can see imaging of acute pyelonephritis with increased cortical echogenicity and a blurred delineation of the upper pole of the kidney. Now, pyelonephritis is usually brought on by ascending infection. Vesicouretal reflux is a risk factor for pyelonephritis. Pyelonephritis presents with leukocytosis, right? Elevated white blood cell count, fever, flank discomfort, and white blood cell casts. The most common pathogens that cause pyelonephritis include E. coli in a large majority of cases, approximately 90%, as well as Klebsiella and Enterococcus faecalis. Tubal atrophy and interstitial fibrosis occur as a result of repeated bouts of acute pyelonephritis. Vesicouretal reflux is the common cause of pyelonephritis in children. Obstruction is a common cause of pyelonephritis in adults. To the right here, we can see that CD68 immunohistochemical staining of the macrophages and giant cells in xanthogranulomatous pyelonephritis. This looks familiar, right? CD68. And to the right here, we can see chronic pyelonephritis that results in cortical scarring with the blunted calyces. Urine analysis may show waxy casts if a patient has chronic pyelonephritis. And the histology of chronic pyelonephritis may show atrophic tubules with eosinophilic proteinaceous debris that resembles thyroid follicles, termed buzzword thyroidization of the kidney. So if you see thyroidization of the kidney, think chronic pyelonephritis. Now let's talk about another very important entity, nephrolithiasis. Nephrolithiasis is the formation of a stone from a urine solute, as seen here on this renal ultrasound of a stone located at the pyloureteric junction with accompanying hydronephrosis. Risk factors for nephrolithiasis include low volume of urine, right? A low urine volume, and a high solute concentration in the urinary filtrate. Nephrolithiasis typically presents as colicky pain, hematuria, right? A little blood in the urine, and tenderness on one flank. Stones normally passes within a few hours. If the stone does not pass by itself in a patient with nephrolithiasis, medical or surgical intervention may be necessary. So you future urologists out there, I'm talking to you. And with that, another lecture is complete. You're well on your way for great success. Keep up the good work. If you have any questions, comments, or concerns, let me know. And I'll see you next time. Take care.